Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of ear, nose, and throat manifestations of syndromes for general pediatricians. Many genetic and congenital syndromes first announce themselves through ear, nose, or throat findings. The pediatrician who recognizes these patterns can dramatically shorten the diagnostic journey, prevent complications, and connect families with the right specialists early. In this lecture, we will walk through 10 carefully chosen clinical cases covering hearing loss, airway anomalies, palatal disorders, facial dysmorphism, and complex multisystem syndromes. By the end, you will have a practical approach to recognizing when a child's ear, nose, or throat finding is actually the tip of a syndromic iceberg. Let us begin. Case study: recurrent ear infections. A 4-year-old boy with trisomy 21 presents for a routine checkup. His mother is concerned about his speech delay and frequent ear pooling. Examination reveals bilateral dull, retracted tympanic membranes. Audiometry shows a 35 decibel conductive hearing loss. What is the most likely underlying cause? Option A, eustachian tube dysfunction and midface hypoplasia. Option B, congenital ossicular chain fixation. Option C, congenital cholesteatoma. Option D, sensory hearing loss due to cochlear nerve hypoplasia. The correct answer is option A, eustachian tube dysfunction and midface hypoplasia. Children with Down syndrome have a uniquely high prevalence of chronic otitis media with effusion affecting up to 80% of patients. Several anatomical factors converge. Midface hypoplasia produces a narrower, shorter, and more horizontal eustachian tube. Generalized hypotonia weakens the tensor veli palatini muscle that normally opens the tube during swallowing, and immune system differences increase susceptibility to upper respiratory infections. The result is poor middle ear ventilation, persistent effusion, and conductive hearing loss that directly impairs speech and language development. Management requires a low threshold for pressure equalization tubes, sometimes called grommets, and mandatory hearing screening every 6 to 12 months throughout childhood. Case study: facial dysmorphism. A newborn is noted to have downward slanting palpebral fissures, malar hypoplasia, and bilateral microchia with external auditory canal atresia. The infant has no limb or vertebral anomalies. What is the most likely diagnosis? Option A, Goldenhar syndrome. Option B, Nager syndrome. Option C, Treacher-Collins syndrome. Option D, Crouzon syndrome. The correct answer is option C, Treacher-Collins syndrome, also known as mandibulofacial dysostosis. The key diagnostic clue is bilateral and symmetric facial involvement. This distinguishes it sharply from Goldenhar syndrome, which is asymmetric and unilateral, and Nager syndrome, which adds upper limb defects. Crouzon syndrome involves craniosynostosis and proptosis rather than malar hypoplasia. Treacher-Collins syndrome is caused by mutations in the TCOF1 gene and follows autosomal dominant inheritance. The classic ear, nose, and throat features are bilateral microtia, oral atresia, ossicular malformations, and conductive hearing loss requiring bone-anchored hearing aids. Airway management is critical in the neonatal period because mandibular hypoplasia can cause severe obstruction. Importantly, intelligence is typically completely normal, which families should be reassured about early. Case study: neonatal respiratory distress. A neonate is born with a very small lower jaw and a posteriorly displaced tongue. The infant experiences significant inspiratory stridor and desaturations when supine, which improve when placed prone. What is the priority in initial management? Option A, immediate surgical tongue-lip adhesion. Option B, prone positioning and airway monitoring. Option C, emergent tracheostomy. Option D, high-flow nasal cannula in supine position. The correct answer is option B, prone positioning and airway monitoring. This is the classic presentation of Pierre-Robin sequence, defined by the triad of micrognathia, glossoptosis, and cleft palate. The term sequence is important. A single primary defect, mandibular underdevelopment in utero, mechanically forces the tongue upward and backward, which then prevents fusion of the palatal shelves. Airway obstruction occurs because the posteriorly displaced tongue falls back into the pharynx, especially when supine. First-line management is conservative. Prone positioning uses gravity to pull the tongue forward and maintain a patent airway, combined with continuous oxygen saturation monitoring and feeding support. If prone positioning fails, escalate to a nasopharyngeal airway, and only then consider surgical options such as tongue-lip adhesion or mandibular distraction osteogenesis. Tracheostomy is reserved for severe refractory cases. Pierre-Robin sequence can be isolated or part of Stickler syndrome, so all infants should be evaluated for associated features. Case study: hypernasal speech. A 5-year-old girl with a history of a repaired submucous cleft palate presents with hypernasal speech and liquid regurgitation through the nose. She has a history of tetralogy of Fallot and frequent infections. Which syndrome should be investigated? Option A, Stickler syndrome. Option B, Kabuki syndrome. Option C, van der Woude syndrome. Option D, 22q11.2 deletion syndrome. The correct answer is option D, 22q11.2 deletion syndrome, also known as DiGeorge syndrome or velocardiofacial syndrome. 3 clues should converge in your mind: a palatal anomaly, often submucous, a conotruncal cardiac defect such as tetralogy of Fallot, and recurrent infections suggesting immune deficiency. This combination is essentially diagnostic. The 22q11.2 deletion is the most common microdeletion syndrome in humans and the most common syndromic cause of palatal anomalies. Velopharyngeal insufficiency occurs when the soft palate cannot completely seal against the posterior pharyngeal wall during speech, allowing air to escape into the nasal cavity, producing hypernasal speech and nasal regurgitation. Other features include a prominent tubular nose, small low-set ears, hypocalcemia from parathyroid hypoplasia, and T-cell deficiency from thymic hypoplasia. Diagnosis is by fluorescence in situ hybridization or chromosomal microarray. Management is multidisciplinary, involving cardiology, immunology, speech therapy, and craniofacial surgery. Case study: failure to pass a nasogastric tube. A newborn presents with cyanosis that improves with crying. The nurse is unable to pass a small feeding tube through either nostril. An urgent computed tomography scan confirms the diagnosis. What other finding is most commonly associated? Option A, coloboma of the eye. Option B, preauricular pits. Option C, macroglossia. Option D, polydactyly. The correct answer is option A, coloboma of the eye. The case describes bilateral choanal atresia, which is a hallmark feature of Charge syndrome. The cardinal feature in newborns is cyclical cyanosis. Neonates are obligate nasal breathers, so when the posterior nasal passages are bony obstructed bilaterally, the infant becomes cyanotic at rest and pinks up only when crying, because crying forces mouth breathing. Charge is an acronym for the major features: coloboma of the eye affecting the iris, retina or optic disc, heart defects, atresia of the choani, retarded growth and development, genital hyperplasia, and ear anomalies. The ear findings in Charge syndrome are highly specific: short, wide, cup-shaped ears combined with Mondini dysplasia of the cochlea on temporal bone imaging. Charge syndrome is caused by mutations in the CHD7 gene and requires multidisciplinary management for complex airway, feeding, hearing, and developmental needs. Case study: pigmentary changes. A 2-year-old girl is brought for evaluation of hearing loss. She has striking bright blue eyes and a small patch of white hair on her forehead. Audiometry confirms profound bilateral sensorineural hearing loss. What is the diagnosis? Option A, Usher syndrome. Option B, albinism. Option C, Waardenburg syndrome. Option D, Treacher-Collins syndrome. The correct answer is option C, Waardenburg syndrome. Waardenburg syndrome is one of the leading causes of congenital hereditary sensorineural hearing loss, accounting for around 2 to 5% of cases. It is an autosomal dominant disorder caused by abnormal migration of neural crest-derived melanocytes during embryonic development. Because melanocytes are also essential for normal function of the stria vascularis in the cochlea, their absence leads to sensorineural hearing loss. The classic features form a memorable triad: sensorineural hearing loss, pigmentary abnormalities including a white forelock called poliosis, and iris heterochromia or strikingly bright blue eyes, and dystopia canthorum, which is lateral displacement of the inner canthi seen in type 1. There are 4 clinical types based on additional features. Hearing loss can be unilateral or bilateral and varies widely in severity, so all affected children need formal audiology assessment and early intervention.